Hello and welcome to the World Massage Conference. We're very excited to be bringing you the very first worldwide virtual massage conference, which has also been recognized as the largest conference in our industry. I'm your host, Eric Brown, along with my World Massage partners and co-host, Scott Dartnell, who will be monitoring the chat room tonight for this presentation, and Melanie Hayden, who will be presenting questions asked by our attendees. In tonight's presentation, which I'm very excited about, we are going to feature James Waslaski presenting on ortho massage. Based on the incredible research recently presented at the Harvard Medical School on myofascial pain and medical research studies found in archives dating back to 1946 on tendinitis versus tendinosis, you'll hear about techniques that will change forever the way you approach myofascial pain, trigger points, and tendon pain. James is going to be discussing some of the unique structural approaches to pain management, where you'll discover what kinds of pain-free multimodality methods are available to learn for achieving immediate and permanent results for complicated pain conditions of the shoulder, elbow, forearm, hand, and wrist. Now, James Waslaski has worked 20 years as a paramedic and in a trauma center while teaching emergency medical courses, and he studied pre-med in college prior to his massage training in Florida. He served as Professional Relations Chair for the Florida State Massage Therapy Association and received the 1998 FSMTA Outstanding State Service Award. He's also served as the American Massage Therapy Association Sports Massage Education Council Chair from 1993 to 1997, receiving the AMTA National Officer Award. He is a self-published author and an international lecturer who has pioneered deep pain-free orthopedic massage, pain management, sports injury, and sports enhancement treatments. His unique structural and multidisciplinary bodywork approach has been taught throughout the United States, Ireland, London, Scotland, Canada, Costa Rica, Puerto Rico, Greece, Australia, and the Caribbean. His seminars are being requested now in New Zealand, South Africa, Amsterdam, Holland, Italy, Egypt, Russia, Dubai even. James was the 1999 recipient of the FSMTA International Achievement Award. Hello, James, and I want to welcome you to the very first World Massage Conference.
Thanks. It's an honor to be part of this prestigious group of educators. I appreciate you asking me to participate.
Great. You certainly get around, don't you?
I do.
Now, I know you have a lot of information to share tonight. I'm going to try to keep us on track with time as much as possible, so we have lots of time for our attendees to ask you some questions at the end. So if you're ready to get started, James, let's just jump right into it.
Sure.
Let's start off by getting you to tell us what exactly orthopedic massage is.
Thanks a lot. I'm going to just go through an industry definition just to open this up. And I think that most of the industry educators would define orthopedic massage involving therapeutic assessment, manipulation, and movement of the locomotor soft tissues to eliminate pain and dysfunction throughout the body. And I think rather than think of it as a technique, it involves extreme degrees of functional assessment skills. Our unique protocol involves a multidisciplinary and multimodality treatment regime. And I think what's unique about our work also is that it has specific client self-care protocols designed for every single clinical condition we address. And the goal of orthopedic massage is to understand and identify the underlying structures involved in each clinical condition and then apply the most appropriate modality or discipline to eliminate the underlying cause. And I think the key here is to treat the cause before addressing the clinical symptoms, which is a unique format. Orthopedic massage training is also uniquely different from one instructor to the next. I think, at least in the United States, many of our educators, they may be really strong in assessment or really strong in treatment. But I think what's really important, and I'm going to explain this later, is the self-care piece involved in this format.
Okay. Now, maybe you can tell us next, what are some of the indications for orthopedic massage and some of the benefits as well?
As you can see in some of the slides, I talked about some clinical conditions. I think they've forwarded the slide. And some of the conditions, I'm just going to list a small part of them, but in this work you can address things like low back pain, sciatica, bulging disc, scoliosis, spinal stenosis, SI joint dysfunction, hip capsule adhesions, which is one of my trademarks, frozen hips, frozen shoulders. We'll talk about that a bit later. IT band friction syndrome, hamstring strains, Achilles tendinosis, plantar fasciitis, ankle sprains, and a list of other conditions in the upper body, including thoracic outlet frozen shoulder, carpal tunnel syndrome, migraine headaches, C1, C2 dysfunction. I'm not going to list all of the conditions, but there's a whole host of conditions throughout the body that certainly we can understand which structures cause these conditions and develop a very user-friendly, systematic approach to bring the body back into balance, which would allow us to treat the cause of these clinical conditions prior to eliminating the symptoms.
And so, just very briefly, can you outline some of the benefits of using orthopedic massage?
Pardon?
Can you outline for us just some of the benefits?
I think some of the orthopedic massage benefits would be pain management would obviously be a given. Injury prevention, we're going to talk later about tendinosis and the cause being, for an example, Achilles tendinosis could be prevented because if we kept flexibility in gastrocs and soleus. We're going to really address a big deal about interacting with sports injuries in the rehabilitation model as far as working with other healthcare providers. A key component in performance enhancement because a body out of pain and a body that's flexible is going to be ideal performing. Also looking at chronic pain and sports injuries and a critical role in structural integration. I also think that this is a new trend in the spa industry that we can integrate any of these particular protocols, forearm, wrist and hand, shoulder, etc., into a relaxation massage. And I think that's a key component in our market and where we're going with this industry.
Okay. Now, you've mentioned that that orthopedic massage isn't really a technique, but rather it's an approach. It's an integrated approach. What kinds of techniques do you use or can be used as part of an orthopedic massage treatment or session?
I think one of the most important key components of orthopedic massage is that we have to do an ongoing functional assessment, checking out range of motion, checking out infill of tissues, doing muscle resistance testing and determining muscle strains and sprains and so on. But I think when we get into the bodywork session, I've been blessed to be trained by some great teachers in myofascial release, neuromuscular therapy, and so on. And what we do is, the more I train, the more I realize that there's a synergy between all these modalities. Typically in our protocols, we start with myofascial work based on the work of Ida Ralph to bring the fascia and the structure and posture into balance. We integrate neuromuscular therapy to treat active muscle belly trigger points. We have a unique role that I'm going to talk about later again on scar tissue mobilization for tendinosis and tendinitis. I like to combine orthokinetics to create joint play and joint mobility. And some of the brilliant work of Dr. Eric Dalton and muscular alignment are implemented into protocols so that we can facilitate both muscular and skeletal balance and alignment throughout the body. Also, we utilize a lot of the work of Aaron Mattis, a great friend and practitioner from Florida, who teaches active isolated stretching and primarily stretching tight muscles throughout the body. Also, we have a component of strengthening weak inhibitor antagonist, which was something I really learned from Phil Page with Hygienics Performance Health and using TheraBand to strengthen weak muscles. And I think really my goal is to bring up the body completely back into balance, to integrate structure, posture, and in bringing the body into balance, I think we can treat joint symptoms more effectively. So we're treating the cause before the symptom here again.
So with your particular approach, you use basically whatever you have available to you. You can integrate it into an orthopedic approach to massage.
I think that's really, the bigger the toolbox, the better the outcome, and the more modalities we have, obviously the better we can affect our patient. And I think in our particular model, we have a user-friendly protocol for balancing out muscle groups around the joints of the body, and we really just base it on restoring normal muscle resting length of opposing muscle groups based on range of motion. And this includes all joints in the body, from the pelvis, shoulder, elbow, wrist, hand, knee, ankle, and foot. I think the unique method allows us to create muscle balance and increased joint space throughout the body prior to treating clinical symptoms that result from myoskeletal imbalance. The other, I think this is really, if I could say that something that's gotten me world recognition as well as created a bit of controversy, and sometimes controversy can be really beneficial to the growth of this industry, is a revolutionary methods for releasing even the most complicated frozen shoulders and frozen hips. And I think the unique...
And those are difficult to treat, too.
Well, I think that there's a mindset in traditional Western medicine about treating frozen shoulders, and I think what sets the work that I teach apart is that we combine science with intention, with compassion, with intuition. If you could imagine doing a dance between adhesions within the capsule, muscle strains around the shoulder, somato-emotional release, emotional guarding, and have a user-friendly pattern of balancing out muscles, fascia trigger points, muscle strains, and a unique method with addressing the adhesions, the fibrosis in the capsule. We've seen hundreds of patients resolve complicated frozen shoulder conditions in as little as one session, and I think that's one of our world-renowned unique traits, and they called it patellar tendonitis. Now we're knowing that in the orthopedic massage that I teach.
Yeah, that would be very unique because it's like I say, most massage professionals have a hard time with those kinds of conditions. So I'm definitely going to have to take your workshops at some point. Now, also another unique trademark is your approach in treating tendon tension or tendinosis versus tendinitis. Is that correct?
Yeah, and this is one I've really, about 14 years ago, I took a workshop in Australia, and I also taught in Australia. And a gentleman approached me on treating patellar tendon. At the time, they called it patellar tendinitis. Now we're knowing that is more clinically called patellar tendinosis. But what we really need to do in our industry is differentiate tendon tension problems from musculoskeletal imbalance, from tendinitis, which most massage therapists will never see tendinitis, and I'll explain that within this protocol, and a revolutionary paradigm shift based on treating tendinosis, which is a muscle strain without inflammation. And we're going to go more into detail, but I think that if I could set my part with my form of orthopedic massage apart with two unique things, it would be releasing frozen shoulders, releasing frozen hips, resolving tendon pain based on the fact that most tendon conditions are not tendinitis, they're tendinosis, and we'll elaborate that a bit more in this presentation.
Okay, well, why don't we elaborate on that right now? No time like the present. So tell us more about the distinction between tendinitis and tendinosis. And I know a lot of people on the line probably have not heard the term tendinosis before.
I think what I'm going to do is, we have to have research. When I was writing a book for a number of years with Lippincott, in the process, I had to find validation to say why I disagreed with deep cross-fiber friction for tendon pain. And so we researched archives from back to 1946, and you can see the medical references here, Krasauer, Nerschel, MDs. And I want to go to the next slide because they were saying, well, the term epicondylitis and tendinitis are commonly used to describe tennis elbow. The dissections, the histopathological studies have demonstrated that tennis elbow is not an inflammatory condition. We're more concerned about collagen disruption. We're more concerned about imbalance of muscles and tendons in chronic situations. Thus, the proper treatment depends on a correct understanding of the nature of the injury, and I'm going to go to the next slide. I just want to share a brief example. About a month ago, I severely injured my supinator playing volleyball, and that would be a form of tendinitis where you had swelling and inflammation and so on. But in a thing called like tennis elbow, where someone has really strong flexors, say a massage therapist, they use their flexors all day, and then they start to force the weak extensors. What happens is we start loading those tendons of the extensors, and we develop these multiple microtraumatic events that cause disruption of the internal structures of the tendon and degeneration of the cells and matrix, which fail to mature into normal tendons. There is an absence, and I want to really emphasize this, because there's an absence of acute inflammatory cells and tendinosis. And I'm going to go to the next slide.
Okay.
Actually, let's go on to the following slide. Let's see. I want to go to the one where it says tendinosis versus tendinitis. Tendinosis is incompletely understood. Although the term tendinitis is used frequently and indiscriminately, these studies show no signs of inflammation. There appears to be a dense population of fibroblasts. When they say they're not sure why it will not heal, I want to refer, I'm just going to jump from the slides for a minute to something that's in their handouts, if I could do that.
Okay, and for people that are listening along, if you go back to your original broadcast page, James is going to be referring to a couple of handouts, and these will be on the page for people that have provided a referral tonight. So not everybody will have these, but in the archived area in the conference for registrants, when you log in, you'll see those there. Unfortunately, we don't have them available for everyone tonight.
I just want to reference something here. And for those of them that are listening, if they just go to the next slide where it says examination of specimens from patients with tennis elbow served as a model for investigation. In saying that, I want to just quote something from research that we just pulled out of documents of tendinosis research. And the references are listed certainly in the handout that you've got. But they said overuse tendinopathies are common in primary care. Numerous investigators worldwide have shown that the pathology underlying these conditions is tendinosis or collagen degeneration. This applies equally in the Achilles, patellar, medial lateral elbow, and the rotator cuff injuries. Unfortunately, distinguishing tendinosis from rare tendinitis, and they're saying rarely will you see tendinitis, is a difficult process clinically. But because tendinosis is far more likely, our advice is to treat patients initially as if tendinosis were the diagnosis. An increasing body of evidence supports the notion that overuse conditions do not involve inflammation. The traditional approach to treating tendinopathies as an inflammatory tendinitis is likely flawed. And they went on to reference 8 areas that we need to look at. And one was the reason for, and I want to reference the extensors of the elbow in reference to tennis elbow. The reason is we have biomechanical and deloading correction problems. In other words, tendinosis results from collagen degeneration and mechanical overload, so we need to determine why it has occurred, why these degeneration of these fibers have occurred. And most of the reasons are because of muscular imbalance. And so as a massage therapist, your flexors are tight, your extensors are weak, you're repeatedly doing backhands in tennis, you're laying down microscopic fibroblast formations without inflammation. So what they're saying now is the load reduction and relative rest. Complete immobilization is not of an injured tendon is contraindicated because the tensile load stimulates collagen production and directs its alignment. One of the things we're going to talk about a little bit later is that if we release the flexors, treating the cause of the overload in the extensors, and we're less aggressive with frictioning on the extensors followed by movement and eccentrically loading, that's the research proven. In fact, it goes on to say that anti-inflammatory strategies, a review on the role of corticosteroids in treating tendinopathy found little evidence they were helpful given the known deleterious effect of corticosteroid injection into tendons and inhibition of collagen repair. The drug, when the drug is injected, they say the treatment has lost favor. So let's go on to the next slide just to build on this research. So they examined tendons of the elbow, the rotator cuff, the patellar ligament, the triceps, the flexors and extensions of the elbow, and even the plantar fascia. They're saying it's not plantar fasciitis. It's a loading of the intrinsic muscles of the foot from tight gastrocs and soleus and so far. So we can move from that slide to the one that says hypothesis. When I had a brilliant experience with Lippincott, and they said when it's just my opinion based on my seminars and my results with my patients to call it a hypothesis. Based on this research study, it is not known why these fibers fail to heal in long-term tendon pain. It is my firm belief, based on many years of tendon pain treatments, that functional collagen or fibroblast formation is only possible when the underlying cause of tendinosis conditions are addressed prior to addressing the microtraumatic symptoms. We must restore normal muscle resting length to antagonistic group of muscles prior to treating the resultant pain, and we must be less aggressive and more specific in our approach to treating resultant strained fibers.
Okay, so this goes very contrary to traditional treatment approaches for...
It really is, and, I've really had a hard time when someone says, don't unload the tendon, just to go to the elbow and do deep frictioning for 6 minutes with the intention of creating more fibroblast formation in the process of inducing inflammation. I strongly discourage it. I strongly disagree with it, and I certainly think that this scientific research is going to revolutionize the way we treat tendon pain versus on treating I think in our industry is creating tendinitis out of tendinosis by being too aggressive with our long-term frictioning, and I stand really strong to that.
Okay. Now maybe, like I can tell you're very excited, you get very passionate about this, and you're like me, you like to talk fast when you get excited. So can we just quickly summarize sort of your approach to treating this again, sort of just break it down slowly, step by step?
I think let's take an example of what would be called lateral epicondylitis or tennis elbow or tendinitis. So the itis piece is really not correct. based on the research I shared with you, that there is not inflammatory. At a cellular level, if you physically look at it, you will not see redness, swelling, and inflammation. Now they're saying, based on biopsy, at a cellular level, the extensor tendon strain is just overuse, and we need to unload the tissues by working, in this case, on the antagonist. So the massage therapist would do things like myofascial release, trigger point, active isolated stretching, but they'd always start with the flexors before they would address the tendon strain in the extensors. When those tissues are completely relaxed in the extensors, they could do a less aggressive and maybe 30 to 45 seconds of multi-directional friction, because really fibroblasts are laid down in multiple directions. Going in one direction doesn't make any sense either. And then what they're saying in the research is that the only way to resolve the extensor tendon strain is to continue to stretch the flexors to keep them unloaded, and then do a movement or what they call eccentric loading. In other words, shortening the extensors, slowly lengthening back to their resting length. So the therapist would go into, the client would go into extension, you would take the fingers and slowly bring them back to a resting length. And they say that the eccentric loading of the weak inhibited muscles is a great way, based on research, to create a functional scar. So the frictioning, I was told in massage school, if you do deep cross fiber friction and you follow it with ice, that the fibers realign themselves. And this new research says, no, that's not true whatsoever, that the frictioning softens the collagen matrix. The movement and the eccentric loading of the tendinosis situation is what creates a more functional tendon fibroblast formation and allows the tendons to heal. So and this is going into the case study we were going to talk about at the end, but that's just in a nutshell. Same thing with the rotator cuff. If we have tight anterior shoulder muscles causing an impingement of the supraspinatus, it starts to degenerate over time. And rather than treating it as a rotator cuff tear or tendonitis situation, we release the tight anterior shoulder muscles, especially the subscap, reposition the supraspinatus, and be less aggressive with frictioning, and be certain to follow that with eccentric loading, which is why I use TheraBand with all of my clients to eccentrically load weak muscles that have been injured to help create a more functional scar. I use Aaron Mattis' work to stretch the tight muscles, and TheraBand to eccentrically load the weak muscles to create a more functional tendon healing. And I think when our listeners go through this research document that I attached as an addition to the notes, this information we're sharing will be highly supported based on research.
Okay, so correct me if I'm wrong. I'm just going to summarize your treatment approach here. So,
okay.
So essentially, your approach first is sort of relaxing or lengthening the antagonists.
If the muscle that's injured is a weak inhibited muscle, like the extensors would be weaker than the flexors of the forearm in most of your clients.
Okay, and that's done as a way to facilitate that weak muscle. And then on top of that, what we do is we strengthen it functionally with eccentric contractions, and that's contracting the muscle while it's lengthening.
So it's two pieces of self-care. We give you something to keep stretching the flexors, because those are the muscles that massage therapists use every day in the forearm. Keeping the flexors flexible allows the extensors to not be so overloaded, and putting tensile force allows the tendon to heal. And then we do the eccentric loading of the extensors. That's correct. And I did put a case study also in a second set of notes that will show more about working on the antagonist before working, like the rhomboids. Here's a better explanation of this extensor flexor forearm thing. You wouldn't want to lie somebody face down and treat trigger points in the rhomboids if you haven't released the pecs and the subscap to relax the rhomboids. Mm-hmm. So the structural approach is important, especially when we come to muscle strains and tendon abnormalities and tendinosis conditions.
Okay. Now, I'm going to move to your next slide here. There's also a hypothesis and research from the first fascial congress at Harvard University.
This is kind of an exciting piece. When I was writing my book about recently, Eric Dalton was with Tom Myers, and they called me from Harvard, and they were so excited about this World Fascial Congress at Harvard University. And one of the comments from Eric Dalton was, he said, whatever you're writing in your book, don't write anything else until you see these studies on fascia. And as we break down some of the breakout studies, there was one particular thing that really caught my attention. It says, evidence indicates that fascia has a stretch reflex, We used to think about the muscle spindle cell, the Golgi tendon response.
Mm-hmm.
This idea that they are certain that fascia has a stretch reflex, thus leading to the idea that kinetic movement may mobilize fascia better than deep static pressure. Certain research experts believe it may take too much deep static pressure to change the thixotropic state of fascia and encourage movement either by the client or therapist. So I was blessed to train with a gentleman by the name of George Kouseleas from the Core Institute. And his movement, it was based on the work of Ida Rolf, but it was sort of a soft Rolfing type of technique. And he would always engage the tissue at a deep level, go with really slow velocity as to not engage a stretch reflex, but have great depth. But he would physically move the fascia, if it's in a shortened position, basically back to its normal muscle resting length. And so some of the theories, get in with your elbow and just hold static pressure, or just position your hands and hold on to those two areas and allow the fascia to move. Based on my understanding of this fascial research and this fascia stretch reflex, I think that they're encouraging now that we create movement on the part of the therapist to mobilize fascia, slow velocity due to the stretch reflex, and even have the client do active muscle contractions and relaxations to better mobilize fascia. And this was a pretty exciting study because we'd seen great other teachers of 5 different experts out there, and everybody has a little paradigm shift. Everyone's uniquely different in their approach to fascia. Mm-hmm. So that was certainly interesting. And then the next thing that came about was the thought about static pressure on tendons to reset the tension of the muscle. They're suggesting that it may be better to have the client contract the muscle with static pressure on the tendon to affect the Golgi tendon response. So where we used to think that we could press on a tendon and it would allow the muscle to inhibit, they're saying that the amount of pressure required to do that might be not good enough, especially based on the fascial stretch reflex and the fact that kinetic movement is what it may take to involve inhibition of the muscle. So I'm encouraging my students to do a fascial model similar to what was taught by George Kouseleas of the Core Institute in Florida, where they're just bringing this tissue in a very slow, deep static pressure back to its state of relaxation, because I think if you do myofascial work first, you're going to be less aggressive if you have to treat trigger points, and you can get in deeper, faster without pain for trigger point therapy, and you can better mobilize everything that feeds joint pain and muscle strains of tendons and so on. So it's just a huge paradigm shift for me, not thinking that I can go in 90 degrees and just hold a lot of pressure and expect the fascial layers to change.
Yeah. Okay, so it involves both static pressure in this second case of eliciting the Golgi tendon response, which inhibits the muscle. Yeah. Research seems to indicate that you want both pressure and a contraction of the muscle at the same time.
Yes, sir. And let's see. Do you have? Did you want to go through the next case study? Or?
Yeah, sure. Let's take a look at the case study.
I think what I'd like to reference is it's kind of going what we talked about before, but I want to just clinically talk about a patient with lateral epicondyle pain, and you let me know when we need to move into the question and answer part, because I think I can address some of these questions on frozen shoulders and tendinosis better when that comes about. But,
okay.
But if someone has lateral epicondyle pain, I think that it's important in our industry that we differentiate, is that just weak inhibited tendons? Is that a group of tight tendons? Is it a muscle strain? And what I do in the seminars is, first of all, if it's lateral epicondyle pain, most of my clients that do massage and work on computers need to have their flexors and pronators released to relax their extensors and supinators on the lateral epicondyle side before they can be treated.
And this is simple reciprocal inhibition. Is that the case?
Well, I think we do modality. I think there is a process. When one muscle group is firing, the others are simply inhibited. And even if I sent you out to strengthen your extensors because your flexors are too strong, they wouldn't be able to fire very well because of the law of reciprocal inhibition. Mm-hmm. So from a clinical standpoint, I think if you massage the flexors and create length working from origin to insertion, and then you massage the pronators to create relaxation in the supinator, then when you go to treat the extensor tendinosis, if it exists through assessment, or the supinator tendinosis, if it exists through assessment, you're treating everything in a relaxed position. I remember years ago when someone would come with lateral elbow pain and they would be in flexion, and I would go and treat the extensor tendons, and it never really got me good results. So now they're saying if muscles are weak and inhibited, treat the antagonist first. In this case of the forearm, treat the flexors and pronators, relax the extensors and the supinators, and then rather than just doing one modality and getting length in the short muscles, do myofascial, do trigger point work, do active isolated stretching, do whatever it takes to restore normal muscle resting length. And if you can imagine this, when I'm stretching your flexors from a shortened position, not only am I restoring normal resting length to the flexors, but I'm relaxing the extensors back to the normal muscle resting length.
Yeah.
It's at that point that you can be less aggressive with what I like to say is multidirectional frictioning to soften the muscle strain matrix if there was extensor tendinosis. In each time you friction the extensors in their relaxed position, you then have to shorten and lengthen them to create a functional scar, and then shorten them and do an eccentrically loading technique, which means they extend, and from extended position you bring them back to neutral pain-free wise, and you just eccentrically load those tendons. And it goes back to what the research is saying. It's not the frictioning that resolves tendon pain. In other words, the debate is, do we want to lay down more fibroblasts and create inflammation, or do we want to unload the muscles and realign the existing strained fibers through creating muscle balance between opposing muscle groups?
Now, where do you feel, because there's now what you're suggesting is most cases, like in the case of what we would call tennis elbow, we think of it as a tendonitis. You're suggesting it's a tendinosis. What's the mechanism for pain in these kinds of cases?
The mechanism for pain goes back to the research in the handouts, and they said that they feel that there's dysfunctional collagen. So every time, it's like a little scab. Every time you pull on a little scab, the fibers are running in different directions, and that pull in the scab stresses out the existing misaligned collagen. They weren't sure why the collagen is not aligning, but they're saying that, let me go back to a piece here. Appropriate strengthening, eccentric strengthening programs have a long track record of clinical effectiveness, and recent research adds further scientific support. It is likely that specific eccentric training results in tendon strengthening by stimulating the mechanoreceptors and tenocytes to produce collagen and thus help reverse the tendinosis cycle. Collagen production is probably the key cellular phenomenon that determines recovery from tendinosis. Animal experiments have revealed that loading the tendon improves collagen alignment and stimulates the collagen cross-linkage formation, which improves tensile strength. Now, here's a classic scenario. You've got a patient whose extensors hurt. The intuitive tendency is to stretch those muscles to think they'll feel better,
exactly.
to keep them loaded, to keep them doing what the flexors were doing, to never let them unload. And I think that constant load on those tendons is causing repetitive breakdown on the fibers without inflammation. When we unload them by stretching the flexors on a religious basis, if that's what we're using every day, it allows some of the healing to occur, but then they're saying that we have to friction, and then in the strengthening phase with the extensors, we have to use TheraBand and focus on the eccentric model, which has really been a long-standing thing anyway in strength training. When you do a biceps curl, it's not the shortening phase of the biceps, but the lengthening phase. Now they're saying it's a more effective thing in tendinosis if we eccentrically load the extensors when we strengthen them. In other words, 1 second concentric contraction, 3 seconds eccentric contraction. It is that process that is producing functional collagen cross-linkage information. And I'm seeing this in patients across the world where they've had tendinitis, which was their diagnosis for years, and in one session they're not having tendon pain anymore.
That's very interesting. Now, I think we're going to start taking some questions. We have, just so you know, we have hundreds of listeners on the line here tonight, and I'm sure Melanie is overwhelmed with questions at this point in time.
Great.
And I want to remind our listeners that we are having some draws tonight. James has donated a couple prizes and a couple prizes from Bodywork Biz. To be eligible to get one of those prizes, all you need to do is submit a question for us in the Q&A box you'll find on the broadcast page. If you can't pull up the Q&A box by clicking the Ask a Question link, then simply click Listen In, and that will bring up the Q&A box, ask your question, and then you can return to the slides if you like. Okay, so let's go to Melanie Hayden to hear some of the questions that have been submitted to James. And James, we're going to put you on the spot.
Great, thank you.
Hi, James. Hi,
Hey,
Eric.
Melanie. How are you?
I'm great. Absolutely amazing presentation, and you're right, Eric. I am bombarded by questions. It's wonderful and really, really awesome questions. So I'm going to do my best to some of them are very similar, so I've kind of been keeping track of what the most common questions are. Number one I'm going to get to you off the bat is people really want to know where they can find you, where they can take your classes. Do you have home study stuff? Where's your calendar? Do you teach in Puerto Rico?
We do have a website, www.orthomassage.net, and we do go all over the world. And one of the things I really want to say, if those listeners own a school in another country, we're always prone to setting up workshops in countries is because I love to travel to the other countries. So they can go to our website and look at our schedule. We do lots of retreat seminars, places like Hawaii. We have taught in Puerto Rico a number of times, and we'd love to go back there and teach again. So if you go to the website and go to the schedule section, and if you're interested in hosting a seminar, certainly just call our toll-free number, which is 1-800-643-5543.
Great, thank you.
And just so listeners know, if you're on the broadcast page right now, there's a contact James Waslaski link on the page. Just click that link, and that will take you directly to his website. You don't have to worry about dropping this broadcast. It'll open in a new window for you.
Great.
And there's also on the trade show. So, yay, we have tons of places to get a hold of you because that was the number one question.
Great.
I have a question from Seth in Houston. And he'd like to know what your view on working in tandem with chiropractic work. Should it be done before or after manipulations? What's the best results in your opinion?
I think it needs to be they need to be done hand in hand. I don't think, after working with people like Eric Dalton, I believe that the balancing of the muscles throughout the body is one small piece. The alignment of the bones is another critical piece. And when we bring the bones and the muscles into perfect balance in the body, you have a real high tendency to be in a pain-free body. But I think a lot of chiropractors are doing both pre-massage and they're doing lesser high-velocity manipulations. If high-velocity manipulation is required, they're doing sort of a post-manipulative massage. So I think there's pros and cons both ways. You could say loosen up the muscles, the adjustment will be more effective. And also you can say if high velocity is necessary, then calm down the muscles and make sure they're in balance. But I think the key piece about chiropractic work is, are we teaching our patients to stretch short, tight muscles and strengthen weak, inhibited muscles following treatment? And that's the bottom line, I think. Muscles pull bones out of alignment.
Thank you. James, there was a couple other questions as well about the term muscle loading. Can you describe that for us?
Yes, I will. In fact, what I'll do is I'll reference, because people know, let's reference the biceps. And let's just say that when you're doing weight training, you pick up a weight and you bend your elbow and you shorten your biceps. That's called a concentric muscle contraction. When you slowly let the weight down, there's a bit of resistance. It's an eccentric muscle contraction. So when I go back to my case study on tendinosis, after I friction, in the old days I would use to ice and not get good results, but after I friction the collagen for a short period of time, I shorten the muscle, and then I have them slowly resist as I pull the muscle back into its resting length from a shortened position. I have them slowly resist that in a pain-free model, and they might be resisting like 5%. And what they're doing is they're doing an eccentric muscle contraction, and the buzzword for that is really eccentric muscle loading, which means, one, it's the best form of strength training because it's during the eccentric contraction we get the greatest benefit of strength, but now the new research is saying that eccentric muscle loading is the best way to realign scar tissue from a muscle strain, from tendinosis conditions.
Thank you for that. Question came in, are there contraindications for orthopedic massage?
Yes, there are, and I'm glad somebody asked that because, doing a psoas work with someone with an aneurysm or doing cervical manipulations with someone that's fallen off a horse and not gotten an X-ray to rule out things like vertebral artery compression. There are really a number of contraindications. As we're continuing to write our book for major publishing, we consistently consult with people that massage patients for cancer and that massage patients with pregnancy. I could list a lot of potential precautions more so than contraindications. I think there are contraindications, like the shoulder is really my specialty, and if there was a critically torn labrum, then orthopedic massage wouldn't help that. But for the most case, there's not a lot of contraindications as much as there are precautions that I would be concerned about.
Excellent. Thank you. Eric, I'm going to have to let you know you will have to also just cut me off when our timing gets close, or maybe you can let me know how much we have right now.
Certainly. I'm the clock keeper, so we have about another 5 minutes for questions.
Okay, great, because there's tons of them pouring in. Here's another one that is very common, and it is we're getting a lot of practitioners looking for that self-care piece. So a specific question, but again, these are real common questions. I have pain in the muscle in the heel of both palms directly over the piriformis. I've been doing massage for over 2 years. Have taken 3 weeks off for healing, but the pain is still present. Any suggestions?
Their question is in reference to a piriformis-related sciatica. Is that?
No, it sounds like wrist injuries, like more for massage therapy.
I think most important, and this is another one of my pet peeves. Here's an example of a massage therapist that does massages, and they massage 5 patients, and they're using their hands. What they're really using is the forearm flexors. So the hand problem is really a forearm problem. And I think that, some of these massage therapists are going home and actually squeezing an exercise ball, which is the worst thing on the planet that they could do, because what they've been doing is strengthening those flexors all day long. That causes tight tendons in the hand, and that causes joint compression of the bones of the hand. So if they would go home and stretch the flexors, and not use the exercise ball, instead use TheraBand and strengthen the extensors. And Melanie, we've got, I think, what is one of the greatest self-care programs in the country today. We've mapped out the whole body for every condition, from hand problems to foot problems to hip problems. And what we've done is taken brilliant work of Aaron Mattis to stretch tight muscles and brilliant work of Phil Page from Hygienics Performance Health to strengthen weak muscles in that order. And we've seen massage therapists, the longevity of their careers have skyrocketed in pain-free bodies because of the self-care that simply just stretches tight muscles and strengthen weak muscles. And looking at that, a hand problem isn't a hand problem, it's a forearm problem. So you've got to stretch the flexors to relax the tendons of the hand to resolve hand problems.
Thanks, James. I know that is an issue with so many of us. So, and people can, again, just make sure that they check onto your website, and they'll get a lot of information. I assume you have a contact information as well for anybody who has questions about things.
We certainly do. They can just go to our website, and if Allison can address questions, she fields them off to me, and we'll certainly handle everything.
Wonderful. Thank you. James, there's a question about the explanation of the collagen matrix and being associated to pain.
Okay, let me go back and reference the research. What the research that I've loaded on the website says that we used to think in the old days that the pain was associated with inflammation, and that we would, let me read the section on anti-inflammatories, that we would inject like anti-inflammatories and corticosteroids and stuff to treat tendon pain as if it was an inflammatory process. And the research that I've literally let them read on the website says that they believe that let me go back to the imaging. Let me see here, biomechanics. Tendinosis results from collagen degeneration and mechanical overload, so determining why it occurred is important. Some of the reasons are muscular imbalances, training errors, faulty equipment, and improper movement biomechanics. And so they're saying that tendons get out of balance, and sometimes the repetitive, prolonged, or chronic situation of tendons out of balance lays down fibroblasts in multi-directions, and that the pain, quite honestly, the research says they're not certain why the disruption of the collagen fibers creates pain, but they're saying one of the solutions to get them out of pain is to create more functional collagen through muscle balancing and the process of eccentric loading the collagen. And I think the hypothesis of scar tissue that I loaded on the research will much more thoroughly answer that question.
Excellent. And you'll have that on your website as well, correct?
We will be loading it on the website. It currently isn't on there, but we'll certainly be getting it up on there because it's so important on this tendinosis situation that I'm so adamant about. As you could tell, I got a little bit excited in the lecture about it.
Excellent. I have a question from Stacy in Toronto.
Okay.
Given that there is no inflammation present, what hydrotherapy if I can speak this properly. What hydrotherapy application would be indicated? Pre-treatment, intervention, post-treatment?
I think one of the keys here is to create heat to the muscle belly. I think a lot of times that unloading the muscle belly, resolving fascial restrictions, trigger points, and bringing muscles back to normal muscle resting like this is an incredible way to resolve joint symptoms and tendon pain. So what I really encourage people is to apply moist heat or heat packs or whatever to the muscle belly, or use things like ProSage or something that creates a heating effect to the tissue and mobilize the muscle belly to restore balance and relaxation to the tendons. So all applications of heat would be beneficial. If I'm having pain throughout my body and I don't have an acute trauma or inflammation, taking a jacuzzi, getting in my hot tub, I always feel better. Stretching tight muscles to relax weak muscles. So all forms of heat application, particularly to the muscle belly, if there's not inflammation, I think would be significant in resolving the symptoms of joint pain.
Excellent. Okay, there's another one on here that I wanted to find that was very similar. I'm looking through probably 80 of these questions now. And,
I wish I had them all. I enjoy that process.
Okay, I'm going to go to the one from Tina here. And she would like to know if you would recommend massage or stretches for a client who has tendon detachment and muscle fiber tears in 3 of the rotator cuff muscles.
Shoulders are really my specialty, and I think that I would need a little. Sometimes you have to do special test evaluation and look at a little more detailed information on this. Tendon detachments, we have to reattach a ruptured tendon, but on first and second degree muscles, if we balance out the muscles surrounding the rotator, in other words, never work on the supraspinatus, infraspinatus, and teres minor if you haven't released the pecs and the subscap. I think the ultimate goal is to bring the tendons of that rotator cuff group back into balance and then determine whether it's a first or second or third degree strain. A complete rupture is really out of the scope of our practice. It has to be reattached. But first and second degree muscle strains, we can have amazing results if we simply start working the front of the shoulder first to relax infraspinatus and teres minor, release the subscap to reposition the supraspinatus, release the upper traps and middle deltoid to drop the humerus off the impingement of the supraspinatus. So we have a brilliant protocol for that we use in the seminars and that we have in our DVDs that would show you perfect resolution. We do have DVDs on all this work, too, that shows the assessment, treatment, muscle order, and self-care. But sometimes I really think, and I want to stick to something important, that in order to treat a complicated shoulder, I need to do evaluations, palpations, and special tests. It's not really something I can evaluate or give advice to over the shoulder if it's extremely complicated. I really need to see that patient, do evaluation, palpation, and special tests, and then determine from there where I would go.
Of course, yeah, that's a challenge, and that's the opportunity people would have through getting the videos or certainly seeing you in person, and just again kind of re-listening to and replaying this broadcast a few times.
Now we are getting close to the end of our time, so unfortunately we're not going to be able to take any more questions. But I want to thank everyone that submitted questions. Really appreciate the response. That's really fabulous. So I want to thank all of you for participating. Now, Melanie, I'm wondering if you can tell us about the giveaways we're doing tonight.
Okay, I definitely can. I'm just going to make one more comment. There's a lot of people, James, that are sending in notes just saying, that they've taken your work and that it's really been very helpful for them. So I just wanted to let you know that we're getting some feedback on that as well. So, we have some great prizes that have been donated by both James and from Eric from Bodywork Biz to give away. And from Bodywork Biz, we have the 60 Clients in 60 Days e-course and the Fill Your Practice 101 e-course. And, James, you have a couple of things to give away. Why don't you tell us about those?
Yes, we were speaking about self-care, and I think we've got such an awesome self-care manual. We're going to give away a self-care manual. We're also going to give away a Volume 5 DVD, which is Complicated Cervical and Pelvic Stabilization. Since we talked about frozen shoulders and complicated shoulders, I'm also going to give away a Volume 4 Complicated Frozen Shoulder video and $100 off of any future seminar.
Wow, fantastic. Okay, I'm going to get you to give us some numbers, James, between 1 and 62. That's how many questions we had come in.
Okay.
And including number 1, of course. And then I'm going to just kind of, while Eric's doing a little bit of closing, I'm going to count down, and then I'll announce the winners, and then I'll get those people to just forward their emails to me so that we have that information.
Okay, you ready?
You bet.
Okay. We'll just go with my lucky number 7, 14, 21.
And you have, I'm sorry, James, your prizes, you have 2 of them?
We were going to give away, did you want to give away the videos as one set or together or no?
Whatever you feel is best.
We can give, for Volume 5, we'll go with number 7, Volume 4, number 14, the Self-Care Manual number 21, and the $100 for any seminar number 28.
Okay, and I need you to pick 2 more because Eric's giving away a couple as well.
How about 49 and 70?
And 70. We only went up to 62.
62 then.
All righty, perfect.
Okay.
All right.
I'll let you carry on, and at the end I'll just announce the names, and then we can get those folks to just fire me off an email with their email address.
Okay, so thank you very much, Melanie. And James, I want to thank you so much for taking time out of your schedule. I know you have a really busy speaking schedule, so we're happy that you've taken the time to join us and have told us a little bit about ortho massage.
And I want to say you guys have an incredible thing going here. You've got some of the greatest speakers in the world, and it was a privilege and an honor to just be considered part of those great people.
Yeah, I have to agree with you. It's a phenomenal lineup of presenters. And we feel that we're very fortunate to have the support we've had to get such an incredible group of people on board. So it's been wonderful to have you here on our very first virtual World Massage Conference. You've given us a lot of information tonight. I think I'm definitely going to have to re-listen to this broadcast, and for anyone that's listening, a replay will be available almost immediately after the call. And if you want to learn more about James' work, which is really quite fascinating, visit his website at www.orthomassage.net, or you can simply click the link on the broadcast page here.